This course will cover the basics of pediatric flexible bronchoscopy. This course involves a few components. Firstly, it will involve this didactic teaching, which will include the indications, contraindications, and techniques of flexible bronchoscopy. It will also include hands-on training in a live procedural workshop, which will include a virtual reality tower and a 3D printed model. Lastly, we will ask participants to assess the simulation tools and course, and the participants will also receive an evaluation on their procedural competency. A flexible bronchoscopy is typically performed for both diagnostic and therapeutic purposes. Diagnostically, it helps to assess the airway anatomy and caliber. It allows for a microbiological assessment to see which bacteria, fungus, molds, or non-tuberculous mycobacteria are living in the airways. It allows for a cytological assessment to look for cancer cells, lipids within the macrophages, protein or hemosiderin within the macrophages. It also allows an assessment of the cell differential if you're looking for lymphocytes in the case of hypersensitivity pneumonitis, or eosinophils in a patient with asthma or another condition. It also has some therapeutic benefits in people with persistent atelectasis, like for example, a patient on ECMO for a long time for whom you need to resolve some atelectasis that's persisted for a week or two, and also in control of a hemorrhage. The vast majority of indications in children is for diagnostic purposes. A flexible bronchoscopy is contraindicated if the family refuses to provide informed consent. The relative contraindications are platelets less than 50 or an INR greater than 5, which would put the patient at risk for bleeding, pulmonary hypertension, cardiovascular instability, or severe hypoxemia or respiratory failure. Now, these are not absolute contraindications. These are high-risk contraindications for which one should strongly weigh the risks and benefits and plan their bronchoscopy accordingly. At this point in time, proceduralists are required to wear full personal protective equipment for all aerosol-generating procedures like flexible bronchoscopies. The future of our protective equipment will be determined based on the future of the COVID pandemic. Before performing a flexible bronchoscopy, it's important to assemble all of the necessary equipment. These are most of the supplies you will need to get prior to starting your procedure. Obviously, you will need a bronchoscope, and we'll talk about the size of the bronchoscope to select. You'll need normal saline syringes for your bronchoalveolar lavage. You'll need Dornase alpha or pulmozyme in somebody who you suspect to have a high burden of neutrophils or pus. You'll need some epinephrine on hand in case there's bleeding. You'll need 1% lidocaine to put on the vocal cords and carina to prevent a laryngo or bronchospasm. You'll need some gauze. You'll need an anti-fog solution to clear up the tip of your camera. You'll need some lubricant to help your bronchoscope pass through the airway. You'll need a swivel adapter, which will connect to the patient's airway and allow the bronchoscope to be inserted into that airway. You'll need a specimen collection trap if you anticipate collecting bronchoalveolar lavage fluid for culture. You'll need sterile specimen cups and requisition forms, and you'll have to decide which labs to send your samples to. This is what my table in the OR typically looks like. Here are my sterile collection cups, my gauze, lubricant, my swivel adapter, some lidocaine, some saline, my sterile collection cup. You'll notice that I don't have epinephrine here. I don't have pulmozyme. Those are oftentimes used only as indicated for certain types of procedures. The head of a bronchoscope on the back has an extension flexion control such that when it's pushed down, the tip of the scope goes up. And when this is pushed up, the tip of the scope goes down. On the other end here, you have a button to capture an image, a button to freeze the image, and your suction port, which is connected to the suction on the wall. Typically, you hold the bronchoscope with your dominant hand at the tip of the camera, which is where you rotate the tip left and right. Your non-dominant hand holds the joystick with your thumb on the extension flexion control and your index finger on the suction. This is an example of one of our current fellows performing a bronchoscopy with his dominant hand on the tip of the scope, inserting it into the swivel adapter, and his non-dominant hand controlling the extension flexion control and his index finger on the suction on the opposite side. You can also notice that members are wearing full personal protective gear with eye coverings and halored masks. The bronchoscopes range in sizes. In pediatrics, typically it's an outer diameter of 2.2 to 6.3 millimeters. You would have to discuss with the anesthesiologist or with your bedside respiratory therapists regarding the size of the airway that needs to be used and adjust your bronchoscope accordingly. All bronchoscopes have a suction channel except for the 2.2 millimeter scopes because they're too small. Now, to manage your airway, there are different ways to do so. You can use an endotracheal tube, but the problem is you won't be able to visualize the glottis. There'll be quite a large amount of friction with the bronchoscope. However, it's a safe option for people at risk of aspiration. A laryngeal mask airway sits right above the vocal cord, so it allows you to assess the vocal cords and other glottic structures. You can insert your bronchoscope directly into the nose without an airway. Now, this is a great way to assess the native airways and the pharyngeal structures, but it's technically more challenging and the airway is not stable. Here is a swivel adapter, which needs to be connected to an endotracheal tube or laryngeal mask airway. For people who have tracheostomies, that is clearly the airway that you would use. Now, we won't go too much into the anesthetic agents used. It is all based on the patient, the preference of the anesthesiologist, or the critical care doc managing the case. But you will probably need to use some lidocaine through your bronchoscope. That's typically the proceduralist that manages the lidocaine. So you would need to have 1% lidocaine, which is 10 milligrams per milliliter. Typically 1 milliliter of 1% is instilled at the level of the vocal cords and carina. So that's 10 milligrams. And you do not want to exceed 8 milligrams per kilogram. So in a 10 kilogram child, you would not want to exceed 80 milligrams. So by putting in 1 milliliter, which is 10 milligrams, you're very far from the ceiling of what you can use for lidocaine. The basic rules of bronchoscopy is that you want to stay off the walls. When you're lost, because a lot of these airways look a lot alike, when you're lost, go back to the carina to reorient yourself. Never advance blindly. You should always have a map of where you're going. The first thing you do is assess the upper airways. So these are obviously the vocal cords. This is just below the glottis, the mid-trachea, and this is a normal appearance of a carina with the right and left main stem bronchi. As you go below the carina, you can see on this diagram on the right that I'm pointing towards an area where the right upper lobe and bronchus intermedius branch off. And that's what you're seeing here, the right upper lobe taking off here, and then the bronchus intermedius right below that. As you advance further into the right upper lobe, or what they call the superior lobe in this figure, you'll see that there's an apical, an anterior, and a posterior segment. As you move the scope down to the bronchus intermedius, you'll see that there's a right middle lobe right here. It looks this way on your video, a right middle lobe, and then the basal segments of the right lower lobe. When you go back to the carina and assess the left side, after you've passed through the left mainstem bronchus and you get to the branch point of the left upper and lower lobes, you have here what looks like the left upper lobe, and the lingula is more distal down into this airway, and the left lower lobe. As you pass further into the left upper lobe, you see that the superior lobe and lingula branch off, and the lingula itself has a superior and inferior segment. As you look closely into the superior lobe or the left upper lobe, you'll see that there's an apical posterior and an anterior segment. You can also see clearly the lingula coming off very closely to where the left upper lobe is. If you move the scope past down into the left lower lobe, you'll see the basal segments of the left lower lobe. This is an example of a bronchoscopy of a 14-year-old female with cystic fibrosis. The image is a little bit blurry, but the point is a lot of white, thick mucus coating the airways, which oftentimes obstructs the view of the bronchoscopy. Here's a scope in a 17-year-old female with primary ciliary dyskinesia. Similarly, lots of mucus coating the mucosa, as well as a large mucus plug here. This is a 1-month-old with bronchomalacia. During inhalation, nicely open patent airways. During exhalation, that airway collapses by nearly 100%. To do a bronchoalveolar lavage, the bronchoscope must be wedged into a bronchus to occlude the airway, and you instill aliquots of anywhere between 10 and 50 milliliters. Of course, if you were doing a unique procedure called a whole lung lavage, that would be very different, but that's a very unique technique that we won't discuss in this course. Typically, you would use a total of no more than 4 milliliters per kilogram. So in a 10-kilogram child, you would not want to use a total of more than 40 milliliters. You expect a return in your suction cup of about 50% of what you put in. That would be a reasonable return. Complications of a bronchoscopy include those associated with the anesthesia itself, aspiration, epistaxis or bleeding, which is generally quite mild, laryngo or bronchospasm, which are usually the most common complications, and that's why we instill lidocaine. Air leak, very rare, and low-grade fever, actually quite common. In fact, I tell all patients that they should be taking Tylenol for 24 hours after the procedure because of a low-grade fever. So in summary, the proceduralist should discuss the indications and risks with the family, obtain informed consent, establish an airway and anesthesia plan with your anesthesia team or critical care team, run a bedside timeout before the procedure starts, instill lidocaine on the vocal cords and carina, and first just take a look, assess the caliber of the airways, the mucosa, the anatomy, and the mucus burden, and then do the bronchoalveolar lavage in 1 to 4 sections, depending on the burden of the disease. Allow for recovery and extubation, and then discuss the discharge and post-op plan with the anesthesia team and with the critical care team. Most patients get bronchoscopies done and go home the same day. In high-risk patients, a post-operative admission to either the general care floor or ICU is needed.